going to talk about care bundles. What does a surgeon care about healthcare associated infections, you ask yourself? Well, I'm one, and I think it's very important. All these things I'm sure you've talked about this week, but the one at the bottom is the one that really interests me, surgical site infection. Sorry, this button's up here. This is what surgeons feel about infection control lectures. I know because I've given them. And you know what it's like to try and get through. Absolutely reiterate what the previous speaker said. I think it's fantastic that we've seen 80% drops in C. diff and MRSA. And it's largely been media driven, as I agree with him. You know, it was a Daily Mail campaign that perhaps pushed us. But we've all gotten into that now in a big way. But why aren't surgical site infections not falling? Well, I think the reason for that is multiple. I mean, I can't remember who I stole this slide from, but if you haven't seen it, doesn't this make you think? Antibiotic introduced on the top, first resistance seen on the bottom. And they all get it. And I can remember being, because of my interest in this sort of field, being invited onto the advisory board of linezolid and daptomycin. And when they came out, we all thought, oh, these are brilliant broad-spectrum drugs, you know, they're not toxic, but expensive. And we all thought they were going to be kept on the top shelf for special infections. And that hasn't happened. And at the end of that line, now, as you well know, we really have no more antibiotics. I'm sure you've all reflected on this far more than I ever did, but can you imagine a world without them? This concept now, I'm just going to India this weekend, and they get very upset when I talk about New Delhi metalloproteinases, because I shall be in Delhi, New Delhi. So we've got to call them carbapenemase producing Enterobacteriaceae. Is that right, Dale? But the point is, you know, because of travel, people like me swanning around, if I pick these bugs up that have this resistance, they're going to come home with me. And if there's no more new antibiotics, we really are in big trouble. We won't be able to do half the surgery we do now, which would be very sad for me. Orthopedics would nosedive. Colorectal surgery would have terrible infection rates. So perhaps we could just go back a bit in time. I've yet to meet a microbiologist who agrees with me on this. Could we use our antiseptics a little bit more completely than we do? Should we use them more consistently than we do? That's the pray and spray machine that Joseph Lister used to squirt in the theatre when he was doing compound fractures. Everybody died with them 150 years ago, and the pray and spray machine with phenol swanning around it, I mean, it must have been awful to operate in. He saved a few lives. So could we think about going back? But there is this concern, I think, about antibiotics and antiseptics, and whether antiseptics might cause antibiotic resistance, or even select super-resistant organism cells. Well, I guess that's theoretical, and the chairman's going to give me a bad time on this, I can just feel it. But there's no real instance yet that antiseptics have caused an epidemic of a human pathogen. And we haven't seen problems with any of these organisms, really. Remember, chlorhex has been around 60 years, iodine for maybe 150, silver to 2,000 years. And the other thing that I spent a lot of my research time is looking at the economics and epidemiology of SSI. When you read the stuff that comes from the, it is stuff from the Department of Health. I'm sorry if I'm upsetting people. They say 2.5% to 5% of operations get SSIs. I think if you really look hard, when you've got a research team, which I've been lucky enough to have, you can times that by 3. A point prevalence has always said, oh, SSIs are the third of the HCAI tree. They're now the commonest in a lot of trusts who look hard. So why aren't they falling? Well, the extract I was lucky enough to chair the NICE guideline on SSI back in 2008. And if they're going to redo it this or next year, which I hope they do, I'd be very pleased to do that again. But the concept of care bundles was around, that concept of matching Michigan, remember all that stuff with central lines. But I think the care bundle also works well with SSIs. What should we include? Well, there's the NICE guideline that I chaired, and now we've got the WHO guideline. And so let's look. What's in common? It's interesting that the WHO guideline doesn't talk about bundles at all. And they certainly don't talk about compliance with bundles. But the WHO guideline, it's just come out this year. I recommend you to look at it. I think it's really the best we have yet. It's up to date, which the nice one isn't. And it's really looking hard for systematic reviews, and it's using all these things like Prisma and now GRADE. I sometimes wonder if we're going too far with evidence. And they use the PICO model, which I think is now general. So you can't really get better data than the WHO have pushed out in their document. But definitions are critical, and I think the definitions we have are okay. I mean, these are very broad brush ideas of contamination risks put together in 1964. And when 90% of them sit in the clean category, from a statistical point of view, it's hard to pull stuff apart. Do you know what I mean? If everything's all at one end. So maybe we should think about re-looking at those. And it's the same with classification. Yes, they're all my patients, and for your interest, yes, they all did go home fine. But superficial and deep incisional SSIs are the ones we need to talk about. The organ space ones are actually quite rare, but they're the ones that kill you. But that's not really related to the surgical bundle. This is a surgical mishap, an anastomotic leak, an infected hematoma. I don't think any bundle will stop you getting them. And I don't really think they should be in the classification. Personal view. Maybe we should revisit that. But the only definition I think you should use is this one. It's the most widely used, but when we looked at the thing in NICE, we found 27 different types of definitions of SSI. So when you're comparing paper for paper, you know, how hard is it to get the feel for things? It's impossible. But that's the one I think you should use. But it gives you categorical data. It's either a yes-no phenomenon. So both those wounds are yes. One's relatively trivial, not to the patient perhaps, but the one underneath is clearly a total disaster. Might lead to amputation, might lead to death. So a very dear friend, who I'm sure you know, Chairman, Peter Wilson, who remains a slightly lovable and very eccentric man. I'm very fond of Peter. He's dedicated his microbiological life to SSI. And he's come up with this idea. You get 5 to 10 points for the score with this acronym. And this gives you interval data from something like 0 to 80. And it gives you a much better idea of what's a severe surgical site infection and what's a trivial one. The top one. Does it need antibiotics, I ask you? Please all of you say no. It needs a stitch taking out. And the one on the bottom certainly does need antibiotics because the patient will be septic and needs some pretty extensive surgery. Merlini synergistic gangrene. I used to see 1 or 2 a year in my practice. Now, surveillance is the key, and we've had interesting fights with Public Health England about this. And surgical site infection data is based on in-hospital data or readmission data. But it really needs to be more robust than that. And if you look hard, your SSI rate will go up by 2 or 3 times. But to have, as I've written in the red down at the bottom, an independent, unbiased, trained observer costs money. And to persuade your chief executive to have 1 or 2 infection prevention nurses dedicated to that, which you could easily justify in a big trust, it's hard work. But do surgical bundles work? Well, interestingly, there's very little data on this. This is the paper we published earlier in the year. A lot of you will know Judith Tanner, who's now in Nottingham. And this was a care bundle preventing SSIs after open colorectal surgery. 13 studies found, a lot of patients, over 8,000, and the SSI rate, if the bundle was followed, or if the bundle was used at all, was halved. But there was no comment on compliance with that. So the fact that SSIs aren't coming down might relate to not just instituting a good care bundle, but compliance with it as well. Now the WHO SSI bundle, there's lots of stuff, and the things that I've highlighted are the ones perhaps I'd talk to you about. Showering, bathing, chlorhexadine's cheap. Is it a risk? I think the evidence is that it's not a risk. It's such a cheap thing to do. You can reduce plenty of skin flora by doing this. But who, like NICE, is it's okay, the evidence. Maybe you should use it. Decolonisation, I talk to the Americans, they can't believe we still screen everybody. for MRSA, and WHO is taking the same view and saying, well, let's screen the really at-risk patients, those having orthopedic or cardiac surgery, or looking for known carriers from a difficult background, like previous hospital admissions and so on. But it's only suppression. You can't decolonise people with MRSA, you know that. Hair removal. If you must remove it, use a clipper, disposable clipper. People even in Turkey will say, we can't afford clippers. And if we bought one, we'd just keep using the same one anyway. It's expensive. But then an ODA came up with this idea, well, why don't you put a little vacuum bag on the back and not have hair floating around the anaesthetic room? He's going to make a fortune. That's it at the top right. We just did a little evaluation earlier this year. Razors are out. And I don't think this is contentious, although, like hair removal antibiotic prophylaxis, the data for this is really quite old. It's 20 or 30 years old, most of it. A lot of these studies were underpowered, lots of problems with them, and I just wonder if, again, we shouldn't just look at this and think again. Is there an alternative pathway? Surgical, this is fascinating to me. Here comes this new toy, and surgeons love toys, I understand that. You know, like babies in the pram, I understand all that stuff. But these are about £5 to £10 a pop as a disposal thing here. But when you pull the trigger, you flood that sponge with 2% alcoholic chlorhex for the skin prep. And the study that was in the New England Journal with that other one I showed 2 or 3 slides before showed a halving of the SSI rate. It wasn't really a very fair comparison because their alternative was the use of aqueous povidone. Not a fair comparison, but there have been studies showing that a similar thing occurs with alcoholic povidone, but chlorhexidine still seems to have the edge. But this one study, I have to tell you, talking to surgeons as I still meet around a lot, I do a lot of talking and teaching and so on, everyone seems to have taken this up. Is that true of your trusts? Are there any operative department people, operating department? I mean, do you use it? I mean, it's widely used on that one paper. And here's the WHO bundle for intraoperative. Again, I've just highlighted the things which seem to be important. Intraoperative warming by any technique using a mattress or a bear hugger, it significantly reduces all those complications. And we've even done this is a paper waiting to be published. We've just finished this systematic review. Warming appears on the forest plot to be unquestionably worth doing. But we only found 4 papers, which surprised me, but pleased me because 3 were from my old unit. Glucose control, again, in cardiac surgery, in diabetics and non-diabetics, keeping the blood sugar around the 7 millimoles per litre mark really does seem to reduce the deep sternal rate. That hasn't translated to other types of surgery, although we always have kept a close eye on blood glucose with diabetic patients. Wound protectors. This was recently published, I got involved with. Outstanding piece of work from West Midlands registrars who looked at this wound protector. My view was it wasn't going to work, but it was a superb trial from a lot of hospitals, from a lot of young surgeons, and they showed the SSI rates, as you can see on the bottom left, were the same in both groups. So this is an expensive toy which you can stop using safely. What about antiseptic use in sutures? This is why I'm here. Lots of potential advantages, because unlike antibiotics, antiseptics hit lots of parts of the cell metabolism. The wall, the efflux pumps, DNA type enzymes and so on and so forth. It's not a specific action. So the risk of getting resistance is probably very small. Theoretical, but it hasn't happened yet. And now there are, in fact, I've got 6 systematic reviews and meta-analyses here on the use of antibacterial sutures. They're all independent, and they're all saying exactly the same thing. Roughly a 20 to 30% decrease in SSIs across the whole range of surgery, all different categories of surgery. And the WHO comment is, use triclosan sutures independent of the type of surgery. So this is a new idea. Well, it's not that new. It's been around 10 years. This technology has been around, but why isn't it happening? This is a paper I published in BJS earlier this year On the left is a forest plot. We threw in every study you could find on antibacterial sutures. RCTs, as long as it was comparative. And again, there's this amazing reduction, look. The random effects ratio is 0.6. That's nearly a 40% reduction of SSI with very tight confidence interval. That's really very significant. And when you look at from HAS data the cost of an SSI and relate it to the sort of the bundles that I've been showing you, including these antibacterial sutures, the antibacterial sutures alone, with that 30% overall reduction of SSI, could save as much as £90 per operation. I can refer you to the paper. It's some clever economic data, but it's, to me, incredibly convincing that you really do save money by introducing them. In dirty surgery, on the bottom right, the saving could be as much as £200 per patient, with something like 15 patients needed to treat. And there's a German group in Heidelberg who everybody believes, certainly in Germany, I'm not so sure about here in the UK, but when things are said in Heidelberg, you do what you are told. And they did a study, which actually was sponsored by the parent company, but there's lots of ifs here. There wasn't that many people in the study. You know, it was only over 1,000 or so. It took them a long time, and there was like 26 or 7 centres, I think, involved in this. Why did it take so long to get this figure? But in fact, the number of wounds that fell apart were less in the antibacterial suture group, but they found no difference in the SSI rates. But they chose SSIs by looking at photographs, and I'm not sure I could tell a deep SSI on a photograph. So I put it into the forest plot underneath. It makes no difference to outcome. So it's a rather equivocal study, but it still, in meta-analysis, makes no difference to the fact that overall there's a 30% reduction. What the PROUD study didn't do was close all layers, the musculofascial layer, the subcutaneous and the subcuticular layers, with an antibacterial suture. You can't seriously expect a deep suture to prevent a superficial incisional SSI, could you? So my recommendation, I'm sure the company probably agree too, is if you close all 3 layers with an antimicrobial suture, then you're more likely to get less SSIs, particularly superficial. One further study came out last year. I think it was in Lancet Infectious Diseases. It came from a Finnish group. This was entirely unsponsored. It just came out of the blue. Nobody knew this was coming. It was a super study, single centre, looking at children and the use, randomised use of antibacterial sutures. And they've shown a reduction, you can see the relative risk there, a 52% reduction of SSIs in kids. Highly significant. And there were no safety issues with these children. So, again, a double whammy from that paper. I might have raced a bit because I'm trying to provoke you to give me some questions. Reading Harry Potter, who I love, I think it's in the last one, he never learned how to repair wounds. Well, I have, but neither of us has learned how to manage infection. And I just wonder, this is a surgeon saying, give me what I want, not what I ask for. Should plus sutures be in your bundle? And I think the answer is yes. Thank you.